Good morning, Andy.
Good morning, everybody. Thank you very much for joining us this morning. If you didn't know me yet already, I am Andy Mabala. I'm a professor of epidemiology, and it's good to have you here this morning. We're going to carry on where we left off last week. You will remember that last week we examined the basic concepts in epidemiology, and the concepts that we addressed is measures of disease, and we looked at the measure of disease occurrence, and we looked at the measure of disease association. And these two measures of measure of disease addresses the three basic epidemiological questions. The first question that these measures address is, to what extent does a disease exist in a population? To what extent does it exist in a population? And when we are asking that question, to what extent does it exist, we are looking for a prevalence. We are asking, what is a prevalence of this disease in a population? The second question that we ask in epidemiology is, at what rate is this growing? At what rate is this disease spreading in a population? When we ask that question, we are looking for the incidence. And this third question is, what is causing the problem, or what are the factors associated with this condition? When we are asking the question, what factors associated with it, we are looking at the two measures of disease, or three measures of disease association. That is relative risk, attributable risk, odds ratio. Yeah, those three measures of disease association. Those are the three questions that you ask in epidemiology before we decide whether to intervene or not. So we said last week, if you are asking a question about to what extent does it exist, you are looking to do an epidemiological study called survey or cross-sectional study. If you are looking to answer a question about to what rate does it exist or does it spread, you are looking to do a study called cohort. You're looking at studies that are observational types of studies. So today we are going to start looking deeper into measures of disease association. That is, we are going to look at observational studies. Does that sound okay? The Princess of Jordan says yes, so I shall just carry on then. And I can see the lady in India, I think it's the Kwa. You are on mute.
You can call me Priya.
Oh, Priya. So, yes, are you in India?
Yes, Andy, I'm in India.
Okay. So yeah, that's what we're going to do today. We're going to look at the observational studies. I said observational studies. There are different kinds of. There are more descriptive type of observational studies, and there are analytic types of observational studies. So today we're going to look at the more analytic type of observational studies. So if I could get hold of my PowerPoint, I'm going to show you PowerPoint for a change. Can I just check that everybody? Am I on the platform where everybody is expecting me to be? Because the numbers that I'm seeing in front of me are a lot less than the numbers that I was expecting. Am I in the right place?
We are in our channel, yes. on Teams.
Okay.
And everyone at your discussion. Yeah.
Okay. Oh yeah. I'm hoping you are going to be able to see a PowerPoint presentation. Okay, you can. Princess of Jordan says yes, you can see it. Yeah. So, what we're hoping to cover this morning is we will we will look at the basic design of cohort study, or that's what we're going to start with anyway. We're going to start with cohort study. So we're going to look at the basic design. We're going to look at the strength and limitation of it. We're going to look at the confounders that are inherent in observation cohort studies, and we're going to look at the analytic procedures for cohort studies. So that's what we're going to cover. Say again? Somebody was asking a question? Okay. So, cohort study. What is cohort study? Cohort study is an observational study in which a group of persons exposed and a group of persons unexposed to a potential cause of disease are followed up in time until the incident of disease occurs, and to compare those two groups in terms of the occurrence of the incident of disease. So that's what the cohort study does. So what we're going to look at with the essential components or elements of cohort study. One is formulating a clear hypothesis. Very, very important that if you are going to be doing a cohort study, you need to be very clear about the hypothesis that you are going to be looking to explore. And you identify the groups of individuals to be studied, and you define the exposure and its measurement, and you measure the confounders, and you define the outcomes. So that's what cohorts, and then you obviously interpret the outcome of your studies. So that is what cohort, those are the essential elements of cohort studies. So there we go. Cohort study is conceptually similar to experimental studies in that both it has two groups, like you would have two groups in intervention and intervention and control group in an experimental study. Cohort study is also consists of two groups. The only difference there, or the main difference between experimental studies and cohort study, is that whereas in experimental studies, those groups are randomly people are randomly allocated to either intervention or a control group. With cohort study, the two groups emerge from the study. Sound like I'm a qualitative researcher now. The two groups, the control groups and an exposure group, emerge from the study rather than being allocated in different groups. How does that happen? As you start with cohort study, you start with people, with individuals who are deemed to be without a disease, and those individuals should have similar characteristics. Oh. Somebody is taking over and is controlling my PowerPoint. Okay. Right. What I'm okay. I have no idea who is taking control of. Hello, Amrit. Imran.
Hello, Andy.
How are you doing, my man?
No, I'm not doing anything.
Good. Okay. Now I've got my PowerPoint back, so I can continue. Um, so I said cohort study is observational study, and cohort study is sometimes is okay. If you switch off your mic, please. Cohort study is also known as prospective study or longitudinal study. It involves selecting people who are free of disease and measure the characteristics of those people and ensuring that they are similar in all the characteristics and follow them up until they develop the outcome that you are interested in. So, in other words, you do not allocate groups, but the groups emerge from the from the study itself. So you then compare the rate at which the disease occur in the exposed group and non-exposed group. The major problem with this type of epidemiological study is that it requires quite large sample, and you follow people for a long period of time, and that means it costs quite a lot of money. I will be giving you a few examples of the of cohort study as an illustration of how big cohort studies can be. So I said the first thing you do is to formulate a hypothesis to make sure that so that we know what you are looking for. And as I said before, the cohort studies are quite time consuming and they are extremely expensive. So how do you go about doing a cohort study then? Let's say, for example, you are looking to see. I'll give you an example of the cohort study that has been going on in the United Kingdom since the 60s, called the Whitehall study. With Whitehall study, individuals when they turn 40, they get enrolled, or in the UK you get a letter when you get 40. You wouldn't know this, you are too young to know. But when you turn 40 in the UK, you get a letter from the GP says to you, would you come to the GP so we can do a checkup, similar to MOT. So you then go to the GP and the GP check your blood pressure, your cholesterol level, and all that. So as part of that checkup, then you get enrolled into the cohort study. So as soon as you hit 40, you get enrolled to the cohort study called Whitehall. And then you will be followed throughout until every year you go to the GP for a checkup. And they check, ask questions such as, do you smoke, do you drink, do you what is your occupation, and they will assess your blood pressure and cholesterol. And then if that year, when you are 41, for example, you're still okay, and then you get a clean bill of health to go home. And then when you get to the age, say of 45, they check the same parameters again, and you may be at that age, maybe say your cholesterol has come up a little bit. Then they will say, oh well, let's watch and see. Do we need to give you an aspirin? Do we need to give you a statin to reduce your cholesterol, or do we need to start you on a small dose of antihypertensive to keep your blood pressure? Or they will prescribe physical activities or lifestyle to reduce the symptoms of a degenerative condition. So as you go through all of that, that is you are part of the of the cohort. But when as you are at the time of enrollment, you are free of disease. They follow you up until you develop the symptoms or the disease that of interest. So in the UK, then we do that. We measure multiple things. For example, how many people who are on unskilled labor who also present with a coronary heart disease. How many people who develop coronary heart disease smoke. We measure multiple outcome. That's one of the advantage of cohort study. They don't take a very long time, but the advantage is that you measure a wide range of things using cohort study. The other cohort study that is ongoing in the United Kingdom, you will have heard of study called Million Women Study. Million Women Study. So this is a study that involved 1,000,000 women. When women tend to the age of I think it's at the age of 51, they get enrolled into the study. And one of the criteria for enrollment is that they are free of any female related conditions such as breast cancer, cervical cancer, and what have ovarian cancer and what have you. So they enroll when they are free of disease, and then they get followed up until to the time later. And during the process of following them up, they get measured things like pap smear and breast examination, mammography, and all that to see how things are going until they develop the outcome that we of interest. So it is 1,000,000 women, so it involves a large amount of people and a large data set. So that is why cohort studies are quite expensive by nature. But I can't emphasize enough the strength of cohort studies, that because they are such a large study, they measure such a wide variety of outcomes. We would be lost without a cohort study. The reason why we are able to explain the health of the population is because of cohort studies such as Whitehall study and the Million Women study. There's a nurses study in the United States that started in the 50s and is still going even today, and measuring different outcomes in the population. So that's a cohort study. It's a prospective study. You enroll people when they haven't got the disease, and then you follow them up, and then during the course of following them up, the groups emerge. There will be a group that is emerging as an exposure group. For example, if you are looking at the association between smoking and coronary heart disease, it may well be that when you enroll people, nobody smoked and nobody had coronary heart disease. But as you are following them up, some people start smoking and some people develop heart disease, and then you measure to see how many people smoke also develop heart disease. And another crucial differences between the cohort study and experimental study is that with experimental study, you are putting an intervention to manipulate the behavior of your sample, whereas in a cohort study, you are observing people. You are not putting any intervention. You are observing people living their normal life, and you see whether their behavior change or not, and if the change of behavior results into a development of any outcome of interest. So that's how cohort works. Obviously, as you are following, if for example you're saying your hypothesis is to see if there is any association between smoking and developing a coronary heart disease. Smoking is not the only thing that would result in development of coronary heart disease. It could be, for example, people who have coronary heart disease, not only they smoke, but they also are obese. It could be that people who have coronary heart disease, not only they smoke, but they are genetically disposed to the coronary heart disease. So there are multiple factors that while the outcome or the exposure of interest to you would be smoking, but and the outcome of interest is coronary heart disease, there may be other things that may influence the dependent variable. So those independent variables that also have an influence on a dependable variable, they are called confounding variables. Yeah. So that is so because it's an observational study. So it is not always possible to account for confounding variables, but there are ways of accounting for them. Somebody is taking over my PowerPoint again. Okay, let's gain it back. I know that the person who keeps taking my PowerPoint is from Nigeria. Hey, people from Nigeria, stop taking my PowerPoint. Got you. So, did I say that? Yeah, I said that with observational studies, then once you have divided this group and you follow them up, then you have to measure the outcome of the disease. So there are several approaches that you could use to analyze the results of cohort study. Some of them include the risk ratio, rate ratio, hazard ratio, attributable risk, and so on. So those are the measures we use to analyze the data that came from cohort study. So in terms of last week, I introduced you to a 2x2 table. So once you have collected your data, then let's go back to the examples that we used last week. Last week we used an example of COVID-19. That is 3 COVID-19 test centers in the UK with a total of 1,318 patients, and age between 65 and 74 tested positive of COVID-19. 660 were from black and ethnic minority, and 658 were from white background. And the investigator then weighted, operative word being weighted. So they were free of, those people were free of serious illness or serious COVID-19 illness at the time of testing. So then the investigator waited to see if these people who are sharing the same characteristic, which is the characteristic they are sharing is that they are between age 65 and 74. And then the other characteristic, the difference is that some of them are white, some of them are of ethnic minorities. And then the investigator followed them up to see if these people who tested positive are going to go on to develop a serious complications of COVID-19. And then the investigator found that 88 of people who developed serious illnesses were from BAME, but there were also 28 from Caucasian who also developed serious illnesses. So then we are required to calculate to see if there is an association between the pain and complications of COVID-19. So we said when you are doing a cohort study, the measure of the unit of measurement you use is either a relative risk or attributable risk. Steph?
I'm here, thanks.
So, are you still following me?
I'm here now, sorry, I've been on late.
You've only just joined.
I couldn't find how to get on, I've been having a nightmare. Thank you though, whoever added me.
I've noticed you lurking on the background. I'll try to invite you.
Thank you.
So, I think the group will thank you because I'm going to recap to make sure that you are up to speed. Yeah.
Thank you guys, really appreciate that, and I apologise to everyone, but thank you very much.
No, we've got oodles and oodles of time. I just realized that I'm almost finished. It's not even 11. So I'm going to use this time to recap then. Yeah. We're doing cohort study at the moment. A cohort study is one of the two observational studies, and we said that cohort study is also called longitudinal study. We said the cohort resembles similarity with experimental study. We said, but the only difference, the major difference between cohort study and experimental study is that, whereas with experimental studies, the two groups, people are randomly allocated into two groups. But with cohort study, it also has two groups, that exposure group and a non-exposure group. But people are not randomly allocated to the exposure or non-exposure group. Instead, the exposure group emerged from the general population or from the general sample. How do I mean by that? I mean, because cohort study, you recruit people who have not got a disease and you follow them up until they develop a disease. So the classification of exposure and exposure emerge from the group. Those people who have got a disease become an exposure group, and those people who have no disease become a control group. Do I make sense, Steph?
Yeah, I'm with.
So we said that the outcomes of then we used an example of Whitehall study, and we said that in the UK you will know that if you ask your parents, they will tell you when they turned 40, they received a letter from the GP. I also did when I turned 40, and the GP asked us to go and test our cholesterol, blood pressure, and all other parameters. In the process, they ask us if we smoke, we exercise, we drink alcohol. They ask the type of job that we do and all that, to look at not only our physical health but our social, our lifestyle. Then they followed us up. They will follow us up until we either develop disease or we do not. So that is part of the study that is going on in the UK called Whitehall study. Whitehall study. So they would follow us up until we develop a disease of income. So you may want to, for example, may decide that you want to see if there is any relationship between smoking and coronary heart disease. You may go to Whitehall data set and ask them if they can give you the data on people who are on the study, so you can analyze to see if there is any correlate or association between this smoking and coronary heart disease. We said, but the problem with asking that question, if there is any correlation between coronary heart disease and smoking, is that smoking is not the only reason why people develop coronary heart disease. There are other factors. For example, if you don't exercise, if you are obese, if you are genetically predisposed to coronary heart disease, all these factors could lead to developing heart disease. So, because your outcome of your exposure of interest is smoking, all other things that may result in coronary heart disease that are not part of your study are called confounding variables. Yeah? Still following that, Lois?
Hello?
Okay.
Andy, can you please repeat that again?
Say again?
Compounding variables. I
Confound.
didn't get that point.
Confounding variables are the variables that could lead to development of the outcome of your interest, but that are not part of your study. For example, if you are interested to see whether smoking causes coronary heart disease, coronary heart disease can be caused by other things other than smoking. For example, you could be obese, you could be genetically predisposed, you could be lacking in physical activities, and that may lead to coronary heart disease. So, all other variables that are not part of your study, but that could lead to the development of the disease of your interest, are called confounding variables. Yeah. We said with cohort study, you've got an advantage of studying not just one outcome, but you can study multiple outcomes because they are big in the nation, and they study the population in its entirety. They study everything that is going on in your life, not only your physical health, but also your social health. So that's advantage of it. So, and we said we're going to measure the outcomes of cohort study. We measure it using relative risk, attributable rate, hazard ratio, and all those outcomes. So we said we're going to stick with the example that we used last week to see how the outcome of a cohort study, because the study that the example of the scenario we showed last week is also a cohort in the sense that it followed people who were tested positive of COVID-19 but who had no complications of COVID-19. They followed them up until they developed complications of COVID-19, and then within that cohort of people, then emerged the exposure group and non-exposure group. So what we are saying now, we want to see if there was our hypothesis is that there is a correlation between or an association between the people of black and ethnic minority and serious symptoms, serious complications of COVID-19. So that is our hypothesis. So we are looking at this data to see if it is true, if we should be rejecting our null hypothesis or accept our null hypothesis. If there is no association between black and ethnic minority and COVID-19, then we will reject the null hypothesis. If there is no relationship, we will accept the null hypothesis. If there is a relationship, then we will reject the null hypothesis. Do I make sense? It make sense, Lo?
Can I just ask a question? When we're looking at studies like this, would our sample, sorry, Stephanie, would our sample you know, our sampling
Yes.
for studies like this? Because would we have to take a similar sort of, you know, we'd have to have a clear sample agenda, wouldn't we, to rule out other things?
Yes, with cohort study, as I indicated earlier, you
Sorry, I missed that bit.
with cohort study, if people will come before the criteria for inclusion would be that we will check all other indicators, their social style, their lifestyle, their occupation, their everything, the past medical history, and their genetic predisposition, and gather all of that information. But it doesn't necessarily mean that we're going to. While our hypothesis is whether there is any correlation between the ethnicity and the serious symptom, we can also, it doesn't necessarily mean that we discount any other things. We will report all other variables that all other outcomes that emerge from our study. But we just our primary, there is something going. When you are doing a study, you have a primary outcome and secondary outcomes. So anything that is not part of our hypothesis, but that is also worthy of reporting, is going to be recorded as a secondary outcome. Do I make sense?
Yeah, that makes sense. Thank you.
Yeah. So I want to stress that in cohort study, the reason why they are so expensive and they are so time consuming is because you would have a rims and rims of a questionnaire where if you've been through to the occupational health questionnaire, you will be completing all those questions before you are included or excluded from the study. And then once you've met all of that criteria, all those things that have been looked at are going to be examined at different stage of the of your life. Yeah. So if you didn't get it last week, now is your chance to calculate the relative risk of developing serious complication of COVID-19 if you are a BAME compared to when you are non-BAME. So I want you to get busy, calculate the relative risk of serious complications of COVID-19 using the data that you are given in front of you. Yeah? So, we said A is the number of people who have got a disease and who are exposed. So, with your mic or take off your mic, unmute your mic and tell me what is A.
88.
It was 88.
She says A is 88.
Yeah.
And tell me what is B.
B is 572. 572.
She is saying B is 572. And tell me what is A plus B.
660.
660. And what is C plus D?
658.
Is 658. So now we've got, what is C?
28.
Let's say again?
28.
28.
28.
So, what is the relative risk of COVID-19 in this data set?
Is the result 3.13?
Say that again. So
3.13.
So a relative risk is A divided by A plus B.
A plus B divided by C plus D. Exposed by not exposed.
Yeah.
Isn't it 1.003?
Is it 1.003?
Yeah.
Are you sure?
Yeah.
0.133. 0.096.
3.0.
One we did last week.
The
I think it's
the
3.1.
the reason why you're giving me so many answers, it tells me that one of those answers will be wrong.
So can I just ask,
Yeah.
with this, do you work out the brackets first? So it would be A plus B and C plus D, and then do you divide A by A plus B? See, I'm struggling with that equation.
Okay. Let's take it step by step. Okay. The formula is A divided by A plus B divided by C divided by C plus D. Yeah. So A is 20 is A is 88.
28.
Is A is 88 divided by
660.
divided by 660. What is 88 divided by 66? Yeah, 660.
0.180.
Oh, say again.
0.133.
0.1. Okay, I'm going to point one person to ask to answer. That's Olu.
0.133.
0.133.
Yes.
So then is C, which is 28, divided by C plus D. What is C plus D?
690. 658.
So what is 28 divided by 658?
0.042.
0.
0.0425.
So what is 0.13 divided by 0.04?
3.16.
Second?
3.16.
3.16.
No.
So
3.2.
so the relative risk is 3.16.
I got something different.
I got 3.25.
If your answer is 3.1 or 3.2, that's fine, because 0.16 is the same as 0.2 as 3.2, I mean.
Yeah.
Sorry, but it's not, it's the risk for exposed, it's not equal A divided A plus B. That means 88 divided 660, 660.
Say that again.
It's the exposed risk, it's A divided A plus B. It's 88 divided 660.
Yes.
Yeah, so that it's 0.0133, not 0.133.
I haven't got a calculator in front of me
No,
here.
I'm calculated on calculator, so it's 0.0, not 0.1, it's 0.0133. And C divided C plus D, it's 0.0425. So the RR number is it's 0.31, not a 3.1.
No, 18 divided by 660 is 0.13.
It is, yeah.
0.013. It's not 0.13, it's 0.0. So,
You want.
no, really, I'm calculating. 88 divided is 0.133.
Princess,
0.150.
Princess of Jordan. Are you sure? Are you sure you're using a numeric calculator?
Oh, okay. Okay, now okay. I'm sorry. I'm not good at math, okay.
Andy, can I just ask,
Sorry
what,
for that.
what was it that we worked out last week then? Because I thought that was relative risk, when we found 1.003.
Well, since then, I realized that people got it wrong. That's why I'm repeating it today. Yeah.
So is that not right last week?
No, it wasn't. Anything that is not what we just found today
Okay.
is not right. So,
So yeah, because we just did A plus B, which was 660 divided by C plus D. That's all we did, didn't we? We didn't do the actual A divided by A plus B divided by C. Do you know what I mean?
yeah.
Because I've written it in the, you can't see it, but I've written it on the table that last week all we did was 660 divided by 658, and that's how we got 1.003.
The equation that is the wrong formula.
Yeah, okay, that was my question.
Yeah.
So I can disregard that.
Yeah. So are we all on the same?
Is that right, guys? I just typed it in the chat. Is that right?
I haven't. Let's have a look at the chart. You can just say it.
Is my I'm just trying to work out if my
Oh yeah. I can see what you. Yeah.
I got it.
Yeah, you've got it.
Well, hey. Okay, I get it now.
You've
I
got-
think it's the out bit that my husband's really good at knowing. Like he has this like saying, and I can't remember what it is, about brackets first and stuff. But it's like looking at that, it's like the order in which you do it. I struggle with.
Okay. Yeah.
That makes sense then. Okay, I'm on the right page.
You're on the right track. So that is how you calculate relative risk. So the same applies when you are calculating the hazard ratio, for example. Rate ratio is or the same equation applies. Yeah.
Well, does it mean that the people who are exposed have 3 times more risk than who are not exposed?
That's a very good question. Yes, that means people who have got the risk is higher amongst the people who are exposed compared to those who are not exposed. And the further away from one, you remember last week. You will remember Lloyd last week. I tried to draw this to show you, but can you see this diagram?
Yes.
Yeah, I tried to draw that last week, but we couldn't see it. So if the relative risk came out and it was 1, that would mean there is no difference between the exposed group and non-exposed group. And because now the relative risk came as a 3.1, so it means the risk is higher amongst those who are exposed compared to those who are not exposed. Yeah. If as Princess of Jordan is suggesting, if it was 0.0 something, that would mean exposure has got protective mechanism. This is quite an interesting one to remember. I was saying to you last week, whenever I pick up a paper and I'm looking to see if there is an association between exposure and the outcome, the first thing I do, I look at the hypothesis and say, what were the researchers looking for? What was their hypothesis? Let's say, for example, I'm picking up an intervention study, and the intervention study is saying we are looking to see if there is any association between taking aspirin and developing stroke. So, because aspirin is given in order to prevent stroke, you would expect that the outcome would be the relative risk of developing stroke will be reduced if you are taking aspirin compared to those who are not taking aspirin. Yeah? So, if we come up with a relative risk of, say, for example, 0.5, so it means the aspirin has reduced the risk of developing stroke. So, what I'm saying...
The term of the vaccination or immunization, do we give the vaccination or immunization to prevent the disease?
Yes.
It's the same idea.
Yeah, yes. So, why I'm pointing that out is some people would say, for example, in this case, there is a positive association between BAME and between COVID-19 and BAME. Or they may say there is a negative correlation between aspirin and stroke. But to say that there is a negative correlation does not necessarily mean bad. It could just be that the negative is what we were looking for anyway. If we give aspirin, you prevent stroke, and if the stroke has been reduced, it will be a number below 1, but that is an outcome that we were looking for. So that is why it's very important that when you are making interpretation of your study, know what was the hypothesis. Yeah? So, that is how you interpret it anyway. So, just to round it up, cohort study is got several advantages, and I've been mentioning the advantages and disadvantages as we go along. But I could just round it out that there is the cohort study measures exposure before the onset of disease, so therefore unbiased in terms of development of disease. It also it's good at trying to establish the rare disease, and it measures multiple outcomes, and therefore is value for money. And the incident can be measured in exposed and unexposed. So those are the advantages of cohort study. The disadvantages is extremely expensive, and exposure change in time. For example, if you were looking at people who enrolled in cohorts in Whitehall studies, some people may, at the time of enrollment, may have been they were young and drinking a lot and partying a lot, and then that exposure, that is drinking and smoking, may have changed over time. At the time when you enroll, somebody may say, I am a smoker. But as soon as they come to the GP and the GP says smoking is not good for your health, they may stop. So that exposure has changed. So that's a disadvantage. But because it's recorded in your data as a smoker, so you may have a false exposure. So that is the disadvantage of cohort study. So, as I said, there are three major cohort studies that I know of that are going on. It's Million Women Study, that is based in Oxford. Yeah.
Sorry, just doing that, can I just clarify? It's prevalence is sort of like how likely something is to happen, and then incidence is sort of the number of actual cases in a population.
The prevalence is the extent to which a disease exists in a population. So it just if for example it answers the question how many people have got a disease in a population.
Okay.
But the incident is answering a question: at what rate is this disease growing in a population? At what rate is it growing? That is an incident.
Okay.
Yeah. And then relative risk is what is associated, what is causing this disease. That's a relative risk.
Okay, thank you.
You're welcome. So I've got these 3 studies linked into your module space. So I would invite you to have a look at the outputs from these studies. Quite interesting outputs have been coming out of this study over the last 50 years or so. Even today, if those of you who are UK based, you will have heard of Marmot studies or Marmot reports. Most of Marmot's reports are generated from Whitehall study. I can see I misspelled Whitehall. Hall is got 2 L's. Is there any question in relation to cohort studies? If there is none, I'm going to move on to case control study.
Actually, I have a question.
Yes, fire.
When we are starting to study, like you said about cohort studies, you said that we can actually get multiple outcomes.
Yes.
So this is in an individual, right? And then let's say, can we even figure out if some disease is occurring in a particular age group? Like, can we know that also with that?
Absolutely. Age and sex tend to be age, sex, and ethnicity are very common confounding variables. So you could stratify it and look at whether the sex age has got anything to do with a condition. Like at the moment, I'm analyzing data. So because I've got numerous outcomes that are that is on my data, every paper that I publish depends on, I ask different questions every time I want to publish something. I ask a different question of the same data. So, like in Whitehall study, lots of people would ask a question about: is there any relationship between coronary heart disease and the type of occupation you are in? Is there any correlation between coronary heart disease and the gender? Is there any, so there are numerous outcomes you could measure from one data set because it's comprehensive in the way that it's collected.
So Andy, you could say that you were measuring, your hypothesis could be that you're measuring, like you just said in that study, the likelihood of the BAME population developing severe competencies, but then a variable could be like, so you could say that we found that BAME where the relative risk was increased, but we also found that more men had worse symptoms. That would be like confounding variable.
Absolutely. And also you could find that yes, there are more BAME that have got developed serious symptoms, but we found that people smoke have got highest in all groups. People who smoke had a higher probability, and you find that Yes, but there is in all groups there were more people who have diabetes who develop serious symptoms. You get it? The advantage of cohort study because it's examining people before the outset of disease occur. It allows us to examine everything that is going on. It doesn't it doesn't bias the exposure.
Yeah.
Are we happy?
Yes, thanks.
Good. Good.
Hi,
So
Andy. I have a question.
yes, please.
I wanted to find out if there's a minimum number of
Yeah.
participants before a study is called a cohort study. If there's a minimum.
Then for cohort study there is no minimum. No.
Oh, okay.
As a general rule of thumb, you would do what we call a power calculation before you decide the sample size. And if you wonder what power calculation is, don't worry. By the time you finish this module, you will know everything about it.
All right.
You sound like you sound like you are in Zimbabwe or Zambia.
I was in Zimbabwe, just arrived yesterday.
Okay, okay.
Yes.
Yeah, your name is either Zimbabwean or Zambian.
Yes, definitely.
So, case control study. I said there are two observational studies. One is cohort study and the other is case control study. So we're going to talk about case control study. I'm just going to say the opposite to what I said to about cohort study. Okay, before we start, what is it that we are looking at? We're going to define a case control study. We're going to define the exposure. We're going to look at how you select cases, how you define the control. We're going to look at how you conduct the field work and plan and analysis and reporting case control study. So that is broadly what we're going to talk about in relation to case control study. So case control study. Let me go back. I can't go back, can I? Unlike cohort study, where you enroll people into the study when they have got no symptoms of this, when they are free of disease, and then you study them until they develop a disease. With case control study, you enroll people when the outcome of interest has already occurred. So they are retrospective studies. Do I make sense? With case control study, the outcome has already occurred, and then you go back to see whether there is any. Are there? Adam. Is that Adam? I didn't quite catch your question, Adam. So yeah, with case control study, the outcome of interest has occurred, and then you go back to see if what were the odds of people were exposed developing a condition, and what are the odds of people who have not developed a disease of developing disease. So you study backwards to see that. So the pattern is the same as with the cohort study. You need to develop a hypothesis to know tell what to suggest the correlation or the direction of correlation. You need to identify the cases. So the cases, identification of cases. Let's say, for example, in one that you've got in front of your screen, if you looking at the E. coli, how would you go about defining the cases of E. coli? Come on, doctors. Any doctors in the house?
Say that again.
How would you define the cases of E. coli? How would you know that somebody is a case of E. coli? Doctors?
By the symptoms?
Exactly. Kabia. Is that Kabia?
It's Khushnud.
Or Khusnud?
Yeah.
Yes. What did you say? How you identify?
I said we'll understand the person is affected by E. coli is by the symptoms.
By the symptoms, such as?
As the patient will have diarrhea or dysentery, abdominal pain, and sometimes vomiting.
Person will have abdominal pain, and they will have diarrhea.
Yeah.
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 But so is somebody who's got a salmonella will have abdominal pain, will have diarrhea, and similarly somebody with a C. diff will have abdominal pain, will have diarrhea, will have vomiting. So how would you tell the difference then?
Blood tests and diagnostics.
You will do blood tests, so you will do microbiology blood. How else will you tell?
Stool sample.
You will send a stool sample. You will send a stool sample, and that will tell you what is growing there. So you've now identified your patients. That some patients that I am dealing, I want to identify people who have got these symptoms of abdominal symptoms, but they must be distinguished from people who have got the similar abdominal symptoms but who have got a different microorganism in their bloodstream. So you are distinguishing that through microbiology investigation. So you can say, okay, if you've got diarrhea, you're vomiting, you've got abdominal cramps, as well as having that, you must have a E. coli. So that's how you're going to be to do the distinguishing issue. We do know that E. coli is one of the condition that is one. It comes from the environment. It's one of the environmentally caused condition. So already, once we identify that somebody has got E. coli, we would like to know where did they get from. Yeah. So you will have to track back to see what caused that E. coli. So how do you go about doing that?
History. I will ask the patient many questions about the source.
Amen. Amen. Exactly. How do you say amen in Islamic language?
Sorry?
How do you say amen in Islamic?
Iman? What do you mean about Iman?
Amen is to say
Amin.
Amen. Absolutely. Amen.
Amin.
So that's what you will look at the history of the patients that are the cases to see what did they eat in the last 5 days, and where they have been, who they have been with. Has anything changed in the way they eat? Yeah? So that is how you are going to identify the cases. You are going to identify the cases by their traveling, their traveling schedule, their eating pattern, and their environmental exposure. Yeah? So how you are going to identify the controls then? That's a hard one, is it? You will identify the control by matching each case with somebody with similar characteristic, but who are not. Yes, again?
Would it be someone with similar symptoms, but they didn't eat the beef?
You would identify the control by somebody who has all other characteristics as the case, but did not have a disease that the case have. Do you get what I mean?
Yeah.
For example, if there was recently there was an outbreak of swine flu in the UK, and what we did, we looked at there was a school that had visited Mexico, and we found that the children who had flu-like symptoms were predominantly those children who had been in Mexico. So we looked at all the kids in the school, not only the kids in the school, but the kids in their surrounding areas. If say for example, a 5-year-old boy in my street is a case of swine flu, we will then look in the street, in the same street where I live, to see if are there any other 5-year-olds in the street. And amongst all other 5-year-olds in the street, is there any 5-year-old who has got flu-like symptoms as well? Why are we doing that? We're doing so that we can rule out that the flu-like symptoms that a patient is presenting is coming from the community they live in. Yeah? So we will do that with all cases to see if within the area they live, are there any other people who've got flu-like symptoms? In the area where they work, if you work, in the school they go to, are there any other people who present the same? So you match each case with more than two control to see if there is any, if there are any other people who have been, there is any differences in exposures between the control and the case. Yeah?
So in this particular scenario, you'd get people who have got a diagnosis of E. coli with the symptoms.
Yeah.
But then controls would be people with the symptoms. But how, I don't understand how you pick them. Like, would they not have a diagnosis of it? So it would be someone who's not necessarily being tested for it, but they've got similar symptoms. Or I don't understand how you select the control cases in that scenario.
The control in this scenario is people who have got no symptoms of the who have no symptoms of E. coli. Everybody who has no symptoms of E. coli is a control. You get it?
Yeah, kind of, but it's just hard without an actual case. Do you know what I mean? Like, for you to directly relate to what the control group would be. Like, I know what you mean, but I'm thinking more about, like, what the environment would be and who particularly you would select. So if you were looking at people in a community with E. coli, it would just be all the other people who haven't got it or who haven't got symptoms even.
Anybody who has not got symptoms but who match the case.
Okay.
Yeah. The control.
So in our this study that match the case, they are either from the same restaurant.
Say that again.
You mean that people have no symptoms but who have the same condition? In this study, that means the people who already eat from this restaurant but they didn't have developed symptoms.
Yes, it may well be. It may well be that people who, some of those people will have had exposure, but are not the case. Did I answer your question?
Yeah, thank you.
Yeah, some of the control may have been exposed, but they just do not have the symptoms. I'm waiting to hear if I'm pausing so that you could digest what I've just said and see if you understand what I mean. Now, perhaps this is going to become clearer when you look at this scenario. Actually, what you are looking at is not a hypothetical scenario. It's a study that was done in the United States, and this is a real scenario. So to measure the outcome of the case control study, we used odds ratio. You remember when we're doing cohort study, the unit of measurement for cohort study was relative risk, but the unit of measurement for case control is odds ratio. So the question that we ask in a case control study, we are asking what are the odds that the cases were exposed, and what are the odds that the control were exposed. I think that statement answers your question, Ezra. Am I pronouncing it correctly?
Yeah, Dr. Ezra.
Yeah. So you are looking at what are the odds that people who were exposed, what are the odds that the cases were exposed, and what are the odds that the control were exposed. Which is why I said to you, Ezra, the controls are all people who have not got a disease, who have not got symptoms. But we are calculating to see what are the odds that even though they haven't got a disease, they were exposed. Yeah? So to do that, we need to have all our numbers in 2 by 2 table. So similarly, A is the number of people who are cases and who have been exposed. B is number of people who are not cases but were exposed. And C is the number of people who were cases but not exposed. And D, I put C twice. This is D, should be D. We can tell I did this at 2 o'clock in the morning when my eyes were a little bit slow. D is the number of people who were not cases and were also not exposed. So you're looking to see what are the odds that people who are cases were exposed, and what are the odds that people who were not cases were exposed. So, what is A?
Is it 8?
Who said that?
Lower biscuits.
It is 8.
If it says analysis showed that 8
That's
ground beef, and it says there was 9 actual cases altogether. One of them people had E. coli, but they didn't buy the beef.
so. What is C then?
Hang on, I thought that's one.
Okay. What is B?
4, 1, 4.
Did you say it's B is 4, Kushner?
Yes.
Yes, it is. And what is D?
19.
How do you know that?
Because it says that people who went to buy beef at the grocery chain, they bought from the grocery chain, but they were not, affected. They were not the cases, but they were exposed.
Ah, the clue is in that sentence that which says 9 cases and 23 controls.
Yes.
So 23 control is would be B plus C.
I just want to do it first. I can't think.
We have a minute to work it out.
Yeah, we just have a minute to try and do it ourselves because we've all just like I need
Light. I can't hear you, Light. Yeah. Yes. Yeah, the sound is very, very bad.
Hello, can you hear me?
I can hear you now.
Okay, I'm lost. I didn't know how the A, B, the C, and the D.
A is the number of people who are cases who also bought beef in grocery store A. So that would be 8.
Okay.
And B is the number of people who were not cases and did not buy beef, or who were not cases but bought the beef in grocery store A. And that's 4.
So, okay, the 4 controls.
The 4 controls, yeah.
Okay, okay.
But how did you arrive at A being 8? I thought it's 9 cases.
Say again?
Yeah, it's 9 cases on the table. I don't know how you arrived at 8.
At 8. At 8.
Yes, A should be 9 cases, right?
No. It is the all cases is 9. So 9 is A plus C.
Oh,
So if A plus C is 9, so C is 9 minus 8.
oh.
Right, I've got an answer for the whole odds ratio. Don't know if it's right, but I've got it.
So how do we work out C for sorry, D, for the ones who didn't have it? How do I get that number?
Which one?
D.
The D.
D.
Oh, the statement is that all control, the number of control is 28. You know, it's 23. Yeah?
Yeah, yeah.
So 23 is B plus D. So if you say B,
With 24.
which is 23, and 23 minus 4,
19.
19. So that is why C is 19.
Right, so we ignore the 32 really, is that right? The 32 is irrelevant.
33.
That's all maths, isn't it?
Yeah, 33. If you look at the table that I presented here, is I excluded all the totals because odds ratio doesn't include the totals in the equation, in their formula.
Where it says 32 subjects, that number 32 doesn't really matter, it's more the controls, is that right?
Yes.
Yes, got it. Right.
So it's right all together, isn't it? The 9 cases and the 23 controls.
Sorry if I'm slowing everyone down.
No. Don't worry. We've got all the time in the world. I'm finished anyway. This is the last task for a day.
Sorry, Andy, I'm really lost.
Okay, Olu. Let's take you step by step, Olu.
Okay.
Yeah. So where are you getting lost? Do you want me to talk you through the 2 by 2 table, or do you want what you want?
From this table, please. I got the 19, 23 minus 4, and everything like that. It's all modeled up in my head.
Okay. Are you looking at this screen?
Yes, I am.
Can you see my cursor?
No.
No. So I want you to write down in your. I want you to draw 2 by 2 in your piece of paper, and have another row below that will make that is A plus C.
Okay.
So A plus C, which is at the in this column, that would be equal to 9.
Okay.
And A, we know that A is a number of people who had the symptoms and we also bought beef in grocery store A. So therefore is 8.
Okay.
So because A plus C is 9, so C would be 9 minus 8.
Okay.
So we also been given that there are 4 people who had no symptoms but who bought beef from the grocery store A. Yeah?
Yeah.
We've been given that 4. So we've also been given that there are 23 control. 23 control is A plus D. This is D, yeah?
Yeah.
So if you say 23 minus 4, what are you left with? It's 19, is it?
Yeah.
So C is 19. No, D is 19. So we've got all our letters now substituted with numbers. A is 8, is B, C is 1, B is 4, D is 19.
Yeah.
And if you look at the formula for odds ratio, it only includes A, B, C, D. It doesn't include the totals. So that is why we didn't bother with totals. We just look at these four numbers, four letters. So we are able to calculate the odds ratio based on the four numbers without including the total.
Yes. Thank you.
You're welcome. So now then, we've got the formula for odds ratio is A multiplied by D divided by B multiplied by C.
I think I've got it. I got it wrong the first time, but I think I've done it.
Is everybody ready to reveal?
Do you want me to tell you how I worked it out?
Okay.
Just in case I'm wrong. First of all, I added A plus D and then divided by B plus C and got the wrong answer. And then I did multiply, so it would be A plus D, so that's 8 plus 19. And then you divide that by B plus C, which is 4 plus 1. No, 4 times 1, sorry. So that's 152 divided by 4. Is that right? That was 38. So if you did 8 times by 19 is 152.
Yeah.
4 times 1 is 4. If you divide 152 by 4, it's 38. Yeah. Am I wrong?
I'm just going to I'm not going to say yes or no, Steph. I'm going to wait for others to say to come up with their own.
I got the same. 38.
38. 38.
Same 38 here.
How many got 38?
I did.
I got 38.
I got 38.
I got 10%. I just did
Okay. Now, I want somebody who got something different to shout out. Who did not get 38?
Me.
Who?
I got 10.857.
Who's that? Is that low?
Yes, I was.
Who else got something different? Khoshnul,
Yes.
I'm interested to hear what you got.
I got 38. It's 152 by 4 and 38.
Olu?
Yeah. I got 38.2. I can use it to I got 38.
Ezra,
Yeah,
what did you what did you get?
It's A multi C over P multi C, so it's 152 over 4, so 38. Is that correct? Oh my god.
Is it correct?
He's leaving it.
Please get the answer, please.
I may be wrong. If how many of you are you? If 40 people, very educated people, come up with 38, then it means I'm wrong.
I think you're wrong.
Yeah.
I think you're wrong. Tell us your formula.
I've got,
Tell, yeah, tell us how you worked it out, Anthony. We'll
uh,
Okay, when you were calculating.
uh,
From the formula, it's obviously for derivatives.
Okay. Maybe we are done.
I've got,
Right.
okay, that this is how I worked it out,
Okay.
which I may be wrong. I got A multiplied by D, which is 8 multiplied by 19.
Yeah.
That's 152.
Right.
And I've got B multiplied by C. So that's 9 multiplied by, what is C?
Oh, that's
Four.
common. Like,
That's
C is 1. That's four.
C is 1, not 9. The culture is 9, so the C is 1.
You are all right. I'm wrong. You see, you see, I was working it out at 2 o'clock in the morning. But you
That's
see,
it. We're all going to fight in a job now.
that's it. You are professors.
Someone bring some coffee for Andy.
Somebody bring coffee for me. Hey, bring a coffee. No, yeah, it's 38.
Oh, that's really made me giggle.
So, that's interesting. Going back to the no, not this one. I can't seem to get my. So how do you then how do you interpret that as a big number? How would you interpret that?
So most of the people who were bought beef from the grocery shop, at least 8 of them got the disease. So that's 38 times more.
Yeah. Those who live in the UK, we had issue with beef in the UK. We were hoping that we were buying beef, but the shops were selling us horse meat.
Scandal. It was awful.
Do you remember?
The Tesco scandal. Yeah, they were slipping a bit of horse meat in.
So, if imagine if you were an epidemiologist and you were asked to to study whether there is an association between buying the odds of buying horse meat when you were thinking that you are buying beef, and if the odds of buying horse when you were thinking that you're buying beef were 38, would you publish that paper? Would you tell the public that the odds of buying a horse meat if you buy beef in Tesco are 38? Would you publish a paper?
So the outcome would be biased.
No. You've done your work and it is perfectly sound, but would you have guts to stand up and say, hey, if you go to Tesco and you buy beef there, guess what? The chances of buying horse meat are 38 times. Would you have guts to say that? Imagine the catastrophe in the economy. You wouldn't, would you?
Well, it would be the ethical thing to do.
Because the thing is that what would happen, people would just not buy beef in Tesco at all, because the odds are just too high of buying horse meat. So if people, and then if people don't buy beef in Tesco, then Tesco's income will suffer. And if their income suffers, they will sue you. And they've got deep pockets to sue you. That is a problem. They have got deep pockets, they will sue you. And as an epidemiologist, our pockets are very, very shallow. We cannot stand.
If it's just something that you're just providing evidence, how can they sue you?
I tell you, Lois, they will sue you like you can't believe.
Yeah, but isn't that, that's bias in itself, you know what I mean? Like, people shouldn't be scared to share evidence for fear of being sued. Like, it's one of them things, isn't it? Like, I don't know.
I tell you, say again?
The word doesn't work that way. I'm talking to Stephanie.
Hmm.
No, it's Lois. Yeah, of course not, but it's, how can you believe what we read then? You know what I mean?
This paper, I want you to download this paper that we've just done now. It's on your model space, and look at how they presented it. They, instead of saying it's 38, they said the odds ratio undefined. Did you get that?
But it's misleading then, though, isn't it? Unless people really look into, I suppose it's up to the people to make their own. The public can't do that.
You see now, Steph. If you read that paper, anybody who has read that paper, unless they've done the exercise that you've just done, they will never know that the odds ratio was 38.
Yeah, that's true.
Because it's presented as undefined. But they did not lie. They just said undefined. They are saying the odds ratio is high, but we have decided as the researchers not to declare it. But you've got all the numbers to calculate it yourself. As you have just done it, you've calculated it, you know it's 38. Everybody in epidemiology community will know it's 38 because they will calculate it. But the man on the street will never know. Therefore, it won't happen.
I'd be taking it to Tesco's and saying, I'm going to publish it, pay me all your money.
Steph, I've been an epidemiologist long enough to know that this